If you have ever sat in a doctor's office, you have probably experienced that very specific brand of like mild underlying confusion.
Oh, absolutely.
Yeah, because you were sitting there on that crinkly paper, covering the exam table, maybe feeling a little vulnerable, and suddenly the physician starts firing off what feels like a completely random sequence of requests.
Right, like they're reading from a secret menu.
Exactly. They ask you to swallow some water.
Yeah.
Then they want you to stick out your tongue.
Yeah.
Then they're asking you to stretch out your arms and hold a piece of paper on your hand.
Yeah, it's bizarre.
And you're just sitting there wondering what invisible clues they could possibly be looking for. I mean, it feels like a magic trick or some secret code you just don't have the cipher for.
From the patient's perspective, it does feel entirely disconnected. You come in for a localized lump in your neck, and suddenly they were scrutinizing how your eyes track a finger moving through the air. But behind the scenes, to the physician, they are not just looking at a lump, they are executing a highly calibrated, perfectly sequenced diagnostic algorithm to evaluate, well, an entire biological system.
And that algorithm is exactly our focus today. For this deep dive, we've got our hands on a pretty special source text. It is an intensely detailed, heavily annotated clinical manual outlining the examination of thyroid.
And it's not just a clean copy either.
No, that's the best part. This isn't a pristine, untouched textbook. It is absolutely covered in medical students' handwritten margin notes.
Oh, okay.
You can literally see the scribbled blue ink where the student was desperately trying to memorize the nuances of this exam, connecting the formal clinical steps to the underlying human biology.
It serves as a fantastic lens for us because the thyroid is it's a master controller of the body's metabolism and neurological tone.
Okay.
So when something goes wrong with it, it doesn't just sit there as a static mass. It actively sends metabolic and mechanical shockwaves through the entire system.
Which brings us to our mission for this deep dive. We are going to decode this step-by-step physical exam from the manual. We will reveal exactly how diagnosing a single swelling in the neck dictates a fascinating full-body investigation from the palms of the hands all the way down to the shins and toes. Okay, let's unpack this, starting with the very first moments of the patient encounter.
Right, so according to the manual, that encounter begins with a very strict formal protocol before the doctor even lays a finger on you.
No touching yet.
None. It starts with an introduction, gaining consent, and exposure. The manual actually provides a literal script for the medical student to memorize. It says, "Hi, I'm Dr. Afak. With your permission, I'll examine your ears, nose, and throat. Kindly remove your glasses and lower your veil."
It sets a really formal stage.
Yeah.
Because right after that, before any physical touching, the doctor goes into pure detective mode. They rely entirely on observation and sound.
Yeah, they categorize these as the 2 tests to listen and the 3 tests to see.
I look at this almost like a master mechanic diagnosing a complex engine issue. A really elite mechanic doesn't immediately grab a wrench and start tearing the engine block apart.
No, they listen first.
Exactly. They have the driver turn the key. They listen to the rhythm of the exhaust. They watch how the chassis shakes. They listen for a felt squeal. All that happens before ever lifting the hood to look at the parts.
The physician is taking the exact same approach. For the 2 tests to listen, the manual instructs the doctor to simply ask the patient to take deep breaths and listen for stridor.
Which is what exactly?
It's a harsh, vibrating, high-pitched respiratory noise. Then they ask the patient to count to 5 and listen for hoarseness.
So wait, we are talking about a physical swelling in the neck, but the doctor is using the acoustic quality of the voice to map it. That's wild.
What's fascinating here is that hoarseness or stridor instantly alerts the doctor to severe mechanical obstructions or nerve invasion.
Oh, because where it's located?
Right. The thyroid sits directly atop the trachea and wraps right around the area housing the recurrent laryngeal nerve.
And that controls the vocal cords.
Precisely. So if the patient has stridor when taking a deep breath or a raspy voice when counting to 5, it tells the doctor immediately that this mass isn't just benignly displacing tissue.
It's doing damage.
Yeah, it is either physically crushing the airway to the point of turbulent airflow, or a tumor has actually invaded and paralyzed a vocal cord nerve.
Wow. The size and aggression of the lump are essentially being measured by sound waves. And I guess that leads into the visual cues, the 3 tests to see.
Exactly.
So the manual says to ask the patient to swallow saliva, or ideally a few sips of water, and watch the neck swelling move. Then ask them to protrude their tongue and look for movement again.
Just watching the mechanics of it.
Yeah, and finally, perform the Valsalva maneuver. That's pitching the nose and blowing out to see if the swelling pops out more prominently. But why are swallowing and tongue movements the primary visual giveaways? I mean, if you're listening to this right now, try swallowing. You can actually feel your trachea moving up and down in your throat.
That physical movement is the key. It all comes down to anatomical anchoring.
Okay, that's right.
Right. The thyroid gland is enclosed in a layer of deep cervical fascia that is firmly attached to the larynx and the trachea. When you swallow, your swallowing muscles pull your entire trachea upward.
Oh, I see.
Because the thyroid is strapped to it, a true thyroid mass has no choice but to bob up and down right along with it.
So if a doctor watches you drink water and the lump stays perfectly still,
They instantly know they're not dealing with a thyroid issue. It's a binary decision point.
that is so simple but so brilliant.
And the tongue protrusion works on a similar anatomical tether. During fetal development, the thyroid actually originates at the base of the tongue.
Wait, really? At the base of the tongue?
Yeah, and then it migrates down into the neck, leaving a tiny residual tract behind called the thyroglossal duct.
Okay.
If a cyst forms on that tract, sticking the tongue out pulls the tract taut, yanking the cyst upward. So just by watching you swallow water and stick out your tongue, the doctor is checking the anatomical tethers.
The Valsalva maneuver is a bit different though, right? Asking the patient to pinch their nose and blow out hard. Why does that make a swelling visibly pop out?
That is about manipulating intrathoracic pressure. When you strain against a closed airway, you drastically increase the pressure inside your chest cavity.
Right, like when you're lifting something heavy.
Exactly. That high pressure prevents venous blood from draining out of your head and neck back into your heart. The blood backs up, the neck veins engorge.
Oh, wow.
And if the mass is highly vascular or extending down into the chest, that sudden back pressure literally inflates the area, pushing the swelling outward so the doctor can see its true boundaries.
Here's where it gets really interesting. Because the manual says, all right, we've used these tests to confirm it is a thyroid swelling. Do we now examine the neck? No.
No, we do not.
The manual explicitly states to jump to account from hands till toe sequence. The examiner completely abandons the site of the actual lump to look at the patient's palms. Why?
Because the thyroid is a systemic regulator. It dictates your basal metabolic rate and sympathetic nervous system tone.
Okay, so it affects everything.
Everything. If it is overactive, pumping out excess thyroxine, the patient's metabolic furnace is just blasting. The doctor looks at the palms to assess for excess warmth and sweating.
Ah, and in the margin notes here, we see the student's quick scribble next to the step that just says temp.
Yep, checking the temperature.
And right after that, another handwritten note says pulse. The manual says to check for tachycardia, a rapid heart rate, or an irregular rhythm like atrial fibrillation.
Right, checking the cardiovascular impact.
But the diagnostic test that really stands out here is the paper tray. The manual says, ask the patient to stretch hands and look for tremors. Put a paper on hand while assessing. That's such a low-fi technique in modern medicine.
It is, but the physics behind it are brilliant.
How so?
Well, a hyperactive thyroid overstimulates the nervous system, causing tiny, rapid misfirings in the motor units of the muscles. It creates a very fine, high-frequency tremor in the hands.
So small you might not see it.
Exactly. It can be so subtle that the naked eye misses it. But if you lay a standard sheet of paper across the back of the patient's outstretched fingers, you are adding a mechanical lever.
Oh, that makes sense.
That piece of paper acts as an amplifier. Even the microscopic motor unit misfirings will cause the edges of the paper to visibly and audibly flutter.
That is amazing. I have to stop you there though, because the next step introduces something called Pemberton's sign. And this is where the manual seems to demand an unreasonable amount of multitasking from the examiner.
It's a lot, yeah.
It says to have the patient raise both arms high above their head for 30 seconds to check for mechanical obstruction. But while the patient's arms are up, the doctor is simultaneously supposed to perform these intricate cranial nerve eye tests.
The H test.
Right. They hold a finger horizontally to look for a lid lag, and then trace an H shape in the air to assess ocular movements. The text explicitly says to do this simultaneously to save time. Are they really asking the doctor to monitor blood flow in the neck while waving a finger in an H pattern to test eye tracking?
If we connect this to the bigger picture, you have to appreciate the sheer efficiency demanded in a clinical setting.
I mean, I guess a physical exam cannot take an hour.
Exactly. Pemberton sign is testing for thoracic inlet obstruction. If you have a massive thyroid, a goiter, they can act like a cork wedged in the top of your chest cavity.
A cork.
When you raise your arms, the collarbones shift and narrow that space even further. If the goiter is big enough, it chokes off the venous blood trying to return to the heart. And over about 30 seconds, the patient's face turns red, they might feel dizzy, and the neck veins visibly bulge out.
The student even wrote, due to mechanical obstruction in the margin for that one.
Yeah, but you still have to stand there for 30 seconds waiting for that venous pressure to build. A skilled physician utilizes that exact waiting window to test the eyes.
Multitasking at its finest.
A hyperactive thyroid causes sympathetic overtone, which overstimulates the muscle that elevates the upper eyelid. The lid retracts and lags behind when the patient looks down, exposing the white of the eye and creating a staring appearance.
Wow.
So the doctor traces the H and moves their finger down, checking the cranial nerves, all while keeping peripheral watch on the neck veins engorging. It's heavily choreographed.
That choreography sets up the next phase perfectly. So we've mapped the shockwaves to the hands, the pulse, the eyes, and the systemic blood flow, but eventually you have to confront the epicenter. You have to touch the neck.
Right, returning to the source.
This is the frontal assault.
The inspection and palpation phase.
The manual dictates, starting with pure visual inspection of the mass. Is the swelling solitary? Is it multi-lobed? Does it have a discharging fistula?
And the student notes summarize this nicely in the margin.
They do. The student wrote site, size, texture, discharge.
Very succinct.
Then we get to the actual touching, the palpation. And amidst all this hyper-efficient checking of cranial nerves and pulse rates, the manual suddenly injects this very human element.
It's an important shift.
It specifically instructs the doctor, warm your hands by rubbing them together before touching the patient, and to ask, I hope it doesn't hurt on touching your neck.
That is a critical technical reminder, not just bedside manner.
Oh, really? It's not just to be nice.
You know, in the pursuit of clinical data, ignoring the patient's comfort destroys your diagnostic accuracy.
How so?
Well, if you put a cold hand on a sensitive, possibly painful neck lump, the patient's natural reflex is to tense their sternocleidomastoid muscles.
The neck muscle.
Right. Once those neck muscles are flexed, they act like a shield. It ruins the doctor's ability to feel the texture or borders of the structures underneath.
So they warm their hands, see if the muscles relaxed, and then the physical technique is incredibly specific. Pressing from one side to firmly palpate the other, they're feeling for something called tracheal crepitus. Now, the manual doesn't define crepitus, but it sounds like a grating sensation.
That's exactly what it is. The trachea is made of cartilaginous rings.
Okay.
If a mass is truly attached to the thyroid, pushing it laterally against the trachea produces a subtle, physical, clicking or grating sensation. That's the crepitus.
Because you are rubbing the mass over those rigid cartilage rings.
Yes, it confirms the mass is deep and interacting with the airway, not just a superficial cyst floating in the subcutaneous fat.
They also palpate the carotids for Berry sign, seeing if the main artery is displaced by the growth. There's a handwritten note to percuss for retrosternal goiter, meaning they literally tap on the sternum, the chest bone, listening for a dull sound to see if the thyroid has grown downward into the chest cavity.
It's all about checking boundaries.
But the sequence that really jumps off the page here is the rapid swapping of diagnostic tools. It reads like a symphony conductor, rapidly pointing to different sections of the orchestra, or maybe a pit crew working on a race car.
Or a chef following a high-stakes recipe.
Yeah. The manual says to use the bell of the stethoscope to auscultate the thyroid for a bruise. Then there's a memorable slogan printed for the students: put the steth down and pick up an IDL mirror. And immediately after, put down the IDL mirror and pick up a hammer.
The reflex hammer.
And from there, instantly checking the lower legs for particular myxedema, the specific skin thickening. Let's break down the biology of this tool swapping. I get the stethoscope listening for turbulent blood flow.
Right, a brute heard through the bell of the stethoscope sounds like a harsh swooshing.
Okay.
An overactive thyroid demands massive amounts of blood to synthesize hormones. The localized blood vessels expand dramatically, and the flow becomes so heavy and rushed that it vibrates the tissues. You use the stethoscope to literally hear the hyperactivity.
But the IDL mirror throws me off.
Yeah.
The tiny, angled, dental-style mirror, unless... Does this tie back to the vocal cords you mentioned earlier during the listening test?
It absolutely does. IDL stands for indirect laryngoscopy. Because the thyroid wraps around the recurrent laryngeal nerve, a malignant tumor invading that space will paralyze the vocal cord.
Oh, so they're looking at it.
The physician slides that tiny mirror to the back of the throat to physically watch the vocal cords open and close. They are visually confirming the nerve damage they suspected when they heard the hoarseness.
And then immediately grabbing the reflex hammer for the knee. How does a neck lump change how your knee kicks?
It comes back to thyroid hormone dictating the speed of your nervous system.
Right, the systemic effect.
Thyroxine regulates how fast nerves conduct action potentials and how fast muscle fibers contract and relax. If you are hypothyroid underactive, nerve conduction slows down.
So the kick is slow.
Yeah, you tap the knee, and the leg kicks back in a sluggish, delayed motion. If you are hyperthyroid, the nervous system is highly excitable. The reflex is violently exaggerated.
So in the span of maybe 60 seconds, by swapping a stethoscope, a mirror, and a hammer, the doctor assesses localized vascularity, cranial nerve invasion in the throat, and systemic neurological conduction speed in the legs.
Exactly.
It is stunning efficiency, but the tone of the exam shifts entirely right after this tool sequence. Up until now, everything has been done facing the patient, but the manual outlines a new section called examination from behind.
This is a crucial shift.
The doctor must physically walk around to the back of the patient, and the steps listed here take on a much heavier, darker tone.
The diagnostic focus changes. From the front, they were diagnosing the functional mechanics of the gland. From behind, they're hunting for metastasis.
The manual says before even performing any more palpation, to give light blows on his spine with a fist while looking towards the patient's eyes. It states spine tenderness may be a sign of metastasis.
Yeah.
Then the doctor tilts the patient's head back to measure exophthalmos, the bulging of the eyes. But they measure it from above, looking down over the forehead with a transparent foot ruler placed on the orbital rim.
Looking from above allows the doctor to gauge exactly how far the eyeball is protruding past the bone of the brow. It gives an objective measurement of how much the tissues behind the eye have swollen due to autoimmune attack.
Then the manual stresses Lahey's method of palpation from behind, noting that in clinical exams, candidates should ideally do this first. The doctor wraps their hands around the front of the neck from behind, pressing from one side to feel the depths of the other.
Right.
They test for proximal myopathy by having the patient shrug their shoulders upward against the doctor's hands pressing down, and then the chilling final request.
Yes, the sign off to the examiner.
The student is instructed to turn to their examiner and formally state, "Sir, I would like to examine her abdomen, liver, and breasts before concluding my examination." The manual clarifies this in parentheses with just 2 words. 4 Mets. So what does this all mean? Why does stepping behind the patient suddenly escalate this into a full-body cancer hunt?
This raises an important question about the reality of what physicians are actually looking for. When the doctor is standing in front of you, they're largely evaluating the immediate disease state.
Like the hormones in airway.
Right. Is the gland making too much hormone? Is it physically blocking the airway? But when they move behind you, they are systematically ruling out the absolute worst-case scenario, aggressive thyroid cancer.
The shift in perspective feels almost metaphorical, like looking behind the curtain,
Moving on the spine with the fist has nothing to do with hormones. Thyroid cancer has a high propensity to metastasize or spread via the bloodstream directly to the bones of the spine.
which is terrifying.
If a secondary tumor has silently weakened a vertebra, a light glow will cause a sharp flash of pain, which the doctor will instantly catch by watching the patient's face.
And shoulder shrug.
Testing the shoulder shrug for proximal myopathy reveals if a toxic overactive thyroid has pushed the body into a severe catabolic state, literally consuming and wasting away the patient's major muscle proteins.
and asking to check the abdomen, the liver, the breasts.
It is the ultimate clinical due diligence. The physician is acknowledging that pathology originating in this tiny 2-inch gland in the neck might have already planted destructive flags in the liver or the breast tissue.
It's a sobering biological reality.
It really is. In medicine, you are never just looking at one isolated part in a vacuum. You are interrogating a deeply interconnected ecosystem where a failure in the neck echoes in the bones of the spine.
That completely recontextualizes how you view a standard medical checkup. We set out to decode the specific manual, and what we found is that the seemingly random checklist of bizarre requests is actually a masterclass in applied human physiology. From listening to the acoustic quality of a raspy voice, to the mechanics of swallowing water, to leveraging a piece of paper to catch microscopic nerve misfirings, to thumping the spine, every single odd request is a highly specific, targeted question being asked of the body's internal network.
Yeah.
A simple lump in the neck demands a thorough investigation of the eyes, the venous pressure, the neurological reflexes, and the liver.
The body will always reveal its secrets, provided the clinician knows exactly where and anatomically how to look.
Which leaves me with one final thought for you to mull over. We have spent this entire deep dive analyzing the purely mechanical, detective-like steps the doctor has to memorize from this manual. We explored the physics of the paper tray, the intrathoracic pressure of the Valsalva maneuver, the neural conduction speeds.
The mechanics of it all.
Exactly. But imagine the psychological experience of the patient sitting on that exam table. You come in worried about a newly discovered bump on your neck. Suddenly, a physician is placing paper on your trembling hands, thumping a fist against your spine, and holding a plastic ruler to your eyeballs to measure how far they bulge.
It's a lot to process.
It must be intensely disorienting and terrifying.